Good morning.
Good morning. Good morning.
Welcome to our second session of the Aging Studies Institute, supported by the Aging Studies Institute at Syracuse University. And again, I'm going to put out a high five to Syracuse University for coming across and sharing their department and their desire to communicate with the community about what Syracuse University Aging Studies Institute is studying and researching and willing to share with groups like this. Syracuse University, Marie and I were just talking, is, I think, as I look at it broadly, a very high quality studying, researching, academic institute. Today I'm going to go up to the I School. Have you been to the I School?
Mm-hmm.
Tell them about the I School. It's
the I School.
It's gangbusters, kids. I mean, you got to see it. If there's one computer in some of those rooms, there's 40 of them. In rooms with the gear, you would think you were going into Google. But anyway, it's very nice of you to come and hear and share and tell your friends about what is going on, not only at the Manlius Senior Center and the Manlius Library, but what we're fostering to bring to your attention and learning experience. Today's speaker is Maria Brown. Maria is the Assistant Research Professor of the Aging Studies Institute at the David Falk College of Sport and Human Dynamics, which is another institution that is up at the school. They took over the law school. You got to see it. And not to negate all the degrees that Maria has, but there's a list of them here, and I'm sure you got it in the announcement. Maria Brown is an assistant research professor in the Falk School and is a John Hanford Foundation doctoral fellow in geriatric social work. We all know what the word geriatrics means. She earned a PhD from Syracuse University Maxwell School of Citizenship and Public Affairs, which is another school you gotta want. I mean, if you gotta go there and see what's going on. You only read about their basketball and football programs, but they're doing academic good work. A dissertation entitled Psychiatric History and Cognition, Trajectories in Later Life, Variations of Sex, Race, and Ethnicity, and Childhood Disadvantage, examine the relationship between psychiatric history and cognitive function in later life. Cognitive function in later life. Get that through your heads. I'm serious. Maria is a social genetologist who uses life course perspective to research the later life experiences of social, economic, disadvantaged individuals, women, racial, ethnic, and sexual minorities. Dr. Brown is also interested in the long-term care expressions of cognitively disabled older adults and caregivers. One other thing, do not think of yourselves as old. Please, because this whole aging is something that happens from the time, and I use this expression all the time, by the time you end up outside the womb. From the moment you are crying and screaming and they cut the umbilical cord, you're in part of the aging process. It so happens that we recognize it as we gather the years. Please welcome Dr. Brown.
Thank you, Louis. Did everybody get a copy of the policy brief that I brought?
No.
Okay, can you
Can I
pass
get
those
one?
out?
Sure.
Yeah, because there's information in there we're going to talk about. It's a sensitive microphone. Okay, so today I'm going to talk to you about what we call triggers of decline in older New Yorkers. So triggers of decline is a conceptual model that I developed with the Health Foundation of Western and Central New York. Is anyone familiar with the Health Foundation and their work?
No. The
Health Foundation of Western and Central New York. Okay, so the Health Foundation of Western and Central New York is headquartered in Buffalo. It's a philanthropic organization. I can't remember exactly where they got their money from, but the money was given to them on the condition that they focus on the western counties of the state and the central counties of the state. So not the Rochester or Albany or Adirondack areas, but the two pockets, western and central. So around Buffalo and around Syracuse. And they focus on vulnerable older adults who are living in the community and children. So they do a lot of child dental care promotion. They do a lot of falls prevention in older adults. So if you've seen falls prevention programming offered by the Office for Aging in like the last 5 or 6 or 7 years, that was funded by the Health Foundation of Western and Central New York. So one of their areas of interest, as I said, is vulnerable older adults. So older adults who are living in the community independently now, but who are at risk for losing their independence. And so the Triggers of Decline model was a way for us to identify all the potential risk factors that can lead to the loss of independence. And that's what I'm going to talk with you about today. So I'm going to go over the model. I'm going to talk about how we can identify at-risk older adults, talk a little bit about interventions we can use, and then we'll have some discussion. Does anybody have any questions so far? I really would like for you to ask questions as we go along, and if it seems better to have more discussion earlier, then I'd want to do that. So if that's what you want to do, let me know. Okay, so like I said, the Health Foundation of Western and Central New York has a mission of improving quality of care and postponing the onset of frailty among older adults and deferring the consequences of frailty. So how can we keep people independent as long as possible in a way that they want, right? So they reached out to us in 2014 to work on this conceptual model, which is a pretty exciting opportunity for me. I'm always interested in engaging with community partners on projects, and so this is a really great opportunity. So I started by doing a comprehensive review of the literature to look at causes of frailty and functional decline in older adults, any effective evidence-based intervention programs that might be out there, and any measures of these potential risk factors for decline in Western and Central New York State. So I'm sure you're aware, or maybe you're aware of the Affordable Care Act and the way that they're pushing for evidence-based practice in every possible way. So that sort of has flown downstream. So now all the foundations also want to work with evidence-based practice, which makes sense because you want things that work. If you're going to invest your money in interventions, you want interventions that work. And focusing on evidence-based practice encourages providers and researchers to document what they're doing and share what they're doing rather than practicing in isolation. So it's a good idea to focus on evidence-based practice. The problem is that there isn't a lot out there because it's a relatively new idea. Yes?
I think there may be more out there, but it's not documented. It's not formally evidence-based because, like here at the senior center, we don't have the resources to document.
Right. Right.
Even though we know we offer successful programs that could pass the evidence-based test.
Right. I mean, the successful programs are important. Evidence-based practice, though, it implies a certain amount of scientific rigor
Yes.
in studying the outcomes of those
Yes.
practices. And so, because a lot of smaller practitioners or providers or senior centers don't have the resources to engage in that kind of research and documentation, then we don't really know what they're doing.
Yeah.
In Europe, in medicine, they have been working on the model of evidence-based practice for a long time. And so they make treatment decisions based on what they know to be effective and what was not effective. And here, our medical establishment kind of resists that model, right? So we end up engaging in a lot of surgical solutions and medical solutions that may or may not improve quality of life or even length of life, just because we don't want to give up on people, but we don't have enough evidence to know what really is going to work, right? So that's the kind of thing that the Affordable Care Act is trying to change. Okay. So in social work and public health, we like to consider the individual in the context of their environment. And so this is based on Bronfenbrenner's ecological theory, which he posed in 1979, and it's been a model that we've been using since then. It's really helpful to understand an individual within the context of their family, within the context of their community, and within the context of larger society. So this is a modification of Bronfenbrenner's system because he also has time as a continuum in his model, but The model that we generally use in social work and public health looks at these 3 layers. We call them micro or individual, meso or community, and macro or system level. And so we tried to build the triggers of decline model following this structure. So this is on page, I think it's page 4 of your policy brief. And this is the triggers of decline model in the ecological systems framework. So you can see on the far left, we start with the individual level factors, risk factors for decline, and then those are surrounded by or encompassed in the family and community level factors, which are then encompassed within the system and society factors. So most of these trigger categories are things people who take care of older adults, either in health professions or social service providers or family caregivers, know from practice or personal experience to be problematic for older adults in terms of triggering decline. So you may be familiar in your role as a caregiver or a friend and neighbor to other older adults, you may have recognized some of these events have affected people that you know. With this project, we endeavored to take the intuitive knowledge and provide evidence both for the importance of these triggers and about how to address them or protect older adults from experiencing them. So a lot of research really is about taking what we kind of know anecdotally and from personal experience and proving it with data, right? So that we can say this is actually a reality. And that's what my doctoral dissertation was all about, was looking at my mother's experience with mental illness and dementia and finding evidence in the data that said, oh yeah, if you have mental illness, you're at higher risk for dementia. So I knew it and I saw it, but I had to prove it with data. So that's really what we're doing with this model also. These are all things that if you work with older adults in any capacity, or if you are an older adult, you already kind of know some of these things are risk factors, but we wanted to be able to provide evidence for it so we can start proposing policy solutions and practice change to address this evidence. One of the things you may notice about the model is that some of these factors on one level might seem like they also would fit on another level, and in fact we did have a hard time sort of separating them out from individual versus community influences. So we understand that it could be configured in a different way, some of them, and so if you wanted to talk about that, we could talk about that. So in terms of the individual level triggers, now if you turn the page in your policy brief, you'll see there's a 2-page chart that lists out all the individual level triggers, and within each of those trigger categories, a lot of examples of what those triggers might be in that category. So we really tried to break it down to very specific things. So the individual level trigger categories are physical issues, falls, chronic disease management, finances, acute illness that precipitates hospitalization, emotional well-being, challenges of managing the home, mental and behavioral health, challenges in terms of food access or nutrition, and poor health literacy. So you can see in the policy brief on pages 6 and 7 that we have the numerous examples, as I said, of each of these categories. And some of these categories, the risks in these categories can lead to other risks in that same category. So for example, if you look at physical issues, there's a risk factor of injuries or physical limitations, which can lead to risks like decreased mobility and decreasing physical activity, which can lead to skin issues. So all those risks in that trigger category can lead to other risks in the same category. And that's kind of how the spiral starts to happen, right? One thing goes, and then you have another experience, and then you're bedridden because of it, and then you have skin breakdown, and then you lose mobility, and then you're all familiar with the move it or lose it theory about physical mobility and activity?
No, only about sex.
That too. That too. If you fall out of practice, it's hard to get back on. But in terms of physical function and mobility, if you don't remain active, you become less active, right? And as you become less active, then you become less active. So I remember when I went to my first meeting of the Gerontological Society, when I was getting my master's in social work, and I saw this woman presenting a poster which basically said, the more you walk, the longer you are able to walk. And I thought, that makes a lot of sense, really. But it had never occurred to me before. The less you walk, the less you are able to walk. So, risks in one category can also lead to risks in other categories. So if you're looking at the physical issues category again, decreased mobility and decreased physical activity can lead to falls or to physical weakness and the fear of falls. So they can sort of hook up with each other. So it was really hard then to say, is falls its own category or should it be in the physical issues category? But we made it its own category because we have so much literature about the impact that a fall can have on older adults in terms of, yes?
Well, the dilemma too is if you fall, I mean, you do have a mental concern about falling again. But also using a cane, doesn't that sometimes lead to always using a cane versus, shouldn't you try to walk without the cane whenever possible, so you gain and do exercises to gain more strength?
Well, that's the tricky thing about a cane or a walker, right? Like you use them to keep yourself safe, but then you do sort of become dependent on them. Or oftentimes older adults then reject the mobility assistive device, right? And then they might have more falls as a result of rejecting the device. So my father-in-law is going through this right now. He's been using a cane for about 6 months because he has a really bad sciatic nerve problem because of stenosis in his spine, so he was falling. So it keeps him from falling, but then he doesn't want to be dependent on it. So he's always leaving it places and then falling or not falling, which is evidence for him that he doesn't need it. And so, but eventually he does fall again. So it's a tricky balance. I mean, he goes to physical therapy, and that's really one of the things that I would recommend it for anyone who's had a fall and needs a cane is to attend physical therapy to strengthen those muscles that are leading to the fall, right? Okay, but we also know that once someone has fallen, then they might fear a fall, and the fear of falling can lead to more falling because you're doing things in a way that you're being overly cautious, or you're not doing things that keep you active and fit. So you walk less because you don't want to fall, and then you get weaker, and then you're more likely to fall. So all of these risk factors can lead to each other. Another example would be the poor health literacy, which can affect an older adult's ability to effectively manage their chronic illness. And emotional well-being and mental and behavioral health can impact each other, and finances can feed into home management challenges. So these are all ways that risk from one category can impact risk from another category.
Or should slow down.
Am I talking too fast? I'm sorry. It's my Central New York Irish. We talk really fast. Okay, so as we're developing the model, we needed to organize these categories in some manageable way. Even though we know they interrelate to each other, there's really no graphic way to represent that interrelation other than what we know about each of those factors. So many of them can be related to or caused by other risks, is the takeaway from the individual level. And you can see there's so many different things that could be considered a risk, right? That you, when you're working with vulnerable older adults, so these would be older adults who are poor or who have some sort of physical disability or cognitive impairment, you really want to try to examine their environment on the individual personal home level even to make sure that you reduce the risks for some of these factors. So if someone is at risk of falling, there are modifications you can make to their home environment that make it safer for them and reduce the chances of tripping, things like that. Is everything making sense so far?
Yes.
Okay. So the next level is the family or community level triggers, which we also call in social work the meso level. In this level, we have identified the risk categories of community resources, social network, care coordination, elder abuse, and caregiving, right? Caregiving, even though it's a role we almost all of us at one point or another have to adopt in our life, it is its own risk factor for decline in older adults who are engaged in caregiving, because the stress of caregiving can undermine your health, and if you don't have access to financial resources, you become impoverished by caregiving, so this is its own risk, caregiving.
Maria,
Yes.
did you look at caregiving too as maybe not being the best care? If one person is responsible for all the care, then perhaps the person who needs the care isn't getting the best care because that person is tired and stressed and...
Right, so that's where community resources and social networking kind of interface with caregiving, right? If you don't have adequate resources, then you can have lower quality care, and you can also have worse outcomes for the patient and the caregiver because they don't have sufficient support. I mean, one of the things that those of us in geriatric social work know is that as a country, we rely very heavily on like informal unpaid caregivers. Like they save us like $250 billion a year in what would have been care provided by paid resources. So we really rely on them, but we don't offer very much support for them.
Signal lost.
Lewis is lost.
Leave me alone, if I can fix this thing, I would. If I had
So-
the guts, I'd throw it against the wall.
Okay. So one of the things that New York State has been doing this in the past year, I don't know if you've heard about this, they have this Alzheimer's disease caregiving initiative that the governor set aside $25 million in the state budget to provide caregiver support on a variety of levels. So one of the ways is to really beef up the Alzheimer's Association chapter network in the state to provide better resources to dementia caregivers. Another one approach is to fund community-based programs who work with underserved populations. So in Syracuse, the program that we are funded here, which I'm co-investigator on, is a caregiver support and education program for African Americans delivered through the churches on the south side. So that's a population that has a lot of trust issues with established agencies and medical institutions, and so you need to reach out to them where they gather, which is in their churches, and we're teaching them about what dementia is and how many people actually live with it and the greater risk that they're facing in terms of dementia in their population and resources that they were formerly not familiar with, like the Office for Aging and the Alzheimer's Association. So in other parts of the state, different populations are being provided for, like in Buffalo, they have one for LGBT older adults. And so speaking of evidence-based practice, these are local models that we believe work and that will document whether or not they're effective, and then we'll try to propagate them across the state and other communities. So that's one of the things that we're trying to do to address the insufficient resources available to caregivers. So one of the things that we offer, all of our programs offer, is respite for caregivers to attend the programming and have someone to keep their person with dementia safe at home. So another way that they normally, if they have financial limitations, would never be able to access programming is the need for respite. So, as you saw on the individual level, on the community level, there are risks that are interrelated and can lead to other risks in other categories on this level. For example, insufficient community resources, poor social networks, and poor care coordination can negatively impact caregivers, which leaves them more isolated and at greater risk for declines in their own health, like we just said. These triggers also leave older adults more vulnerable to elder abuse. Caregivers may sometimes engage in elder abuse if they are struggling with these other trigger categories like lack of adequate resources, no social support, poor care coordination, or the inability to afford paid caregivers or respite workers. So they themselves can be impacted, but they may also harm or neglect their patient because of the lack of resources in these other areas. So the third level is the system or society level triggers, and these are medication management, the impact of hospitalizations, care transitions, transportation needs, and disparities in access to resources. So medication management is an issue if you have memory impairment and you can't remember to take your medication, or if you can't afford to take your medication as prescribed. So sometimes you see people who are taking their meds like every other day to stretch out the medication because it's so expensive to buy. Impact of hospitalizations are all the ways that being hospitalized can affect your physical function and your emotional and physical well-being. So you may already be aware that if a person over the age of 65 is hospitalized and spends 3 days in a hospital bed, the reason why we provide inpatient rehab after those 3 days is because you can lose a lot of physical function in just those 3 days. And the older that we are, and the more time we spend in bed, the more physical impairment that leads to. So, yeah, a kid could be in the hospital for a week with pneumonia and get up and they're just like their old selves again, but we don't bounce back as quickly as we get older. So being in a hospital and not being physically mobile can lead to what we call hospital-induced disabilities. right? So you might go in because you had pneumonia, and before you went in, maybe you were perfectly fine in terms of walking, and when you get out, you need a walker because you lost your capacity to walk independently while you were laying in that bed. So we want to prevent those hospitalizations, but then we also want to promote the idea of providing exercise opportunities while someone's in the hospital to limit the impairment that they get from actually being in the hospital. Does that make sense? Okay. So care transitions, it was very popular a few years ago now to talk about the Coleman model of care transition management. So basically Eric Coleman is a physician out in Arizona, and he had this model. He basically, through his research, found that when a person is discharged from the hospital to home, the most of the problems they might experience in that transition are related to lack of appropriate communication between the hospital physicians and their personal physician, and a lack of understanding on the part of the patient about what those communications to the other physician should be. So sometimes the hospital will fax discharge orders to a physician's office on a weekend, which is usually when we end up getting out of the hospital for some reason, and that those papers might get lost, and the physician won't know that you were in the hospital or that you had new medications after the hospital, so they're not monitoring you for medication interactions, and all these things can lead to rehospitalization within 30 days, especially in older adults. So care transition management is really about making sure those communications happen, maybe having follow-up calls from the hospital to home to make sure that you're doing everything that they told you to do at the discharge plan, because it's hard sometimes to remember everything they tell you you need to do when you go home. So a follow-up call or two is very helpful, and simple programs like that have been shown to have really great results in terms of eliminating the need for rehospitalization and discharged adults from hospitals. So,
Mary,
yes.
they're also saying that if you have a choice, you should not schedule surgery on a Thursday,
Right.
because the staff, there's less staff available to you, and so the care you get post-op might not be as good as if you had scheduled the surgery on a Monday.
Right. They also
you'd be enjoying the weekend.
right.
Yeah.
So you can get discharged on the weekend, which means you can't do follow-up with anybody for like 2 days. And they also say you should never have surgery in July. Do you know why that is? Because that's when the new surgical residents start, and they are exhausted. And so the chances of you having surgery with people in the room who have not had sufficient rest or experience are higher if you get a surgery in July.
That's all good information.
Well, it depends on the health system you're in. It depends on the model they're using. So unfortunately, not very many hospitals offer formal care transition follow-up. But I don't know if the last time you've had a same-day surgery, but usually now, if you have a same-day surgery, you get discharged to home. They call you the next day and they say, "How are you doing?
Yeah.
Do you need anything? Don't forget to follow up with your doctor." That's sort of like a lower cost way to do some care transition, but that's not from a hospital stay, that's just from a surgery. So they might follow up like once or twice after a hospital stay. It depends on how the hospital has organized that. So it should probably be a nurse care manager versus a social worker, because social workers, we might know all about resources that you could access in the community, but we don't know anything about symptomology or side effects of medications or signs of infection or anything like that a nurse manager would know. Unfortunately, when hospitals hit budgetary crises, the first things they cut are things like social workers and discharge follow-up and stuff like that, because they're ways to save money. And they don't really see the inherent financial value of keeping us out of the hospital, right? Because they get paid if we go in, so, yeah. Well, they get penalized now by the Affordable Care Act if there's too many rehospitalizations and if you get an infection while you're in the hospital. But really, if patients are in the hospital, they can't collect money from insurance companies. So they do get paid if we use the hospital, right? So it's hard to say rehospitalization will save you money, because really it may not save them money. So, yes?
So you mentioned the Affordable Care Act. What are the points that you're making about that in relationship to the subject?
Well, the Affordable Care Act really encourages research on evidence-based practice and patient-centered care, and so those things are directly related to triggers of decline, because we're trying with this model to point out all the gaps in evidence-based practice for addressing and reducing the effects of these triggers. And since a lot of these triggers are related to physical health and medical care, that's where the connection is.
What, I don't understand, are they paying you to do the Affordable Care Act?
No.
Pays you to do this?
No, this work I did for the Health Foundation of Western and Central New York. But the Affordable Care Act does fund research on evidence-based practice. It's just that this particular project wasn't funded by the Affordable Care Act. I'm in the middle of applying for a grant that comes out of the Affordable Care Act for patient-centered research on chronic disease management. But this is just a community-funded effort to identify areas that we might need more evidence for.
And the Affordable Care Act doesn't want you going into the hospital very much?
Well, the Affordable Care Act penalizes hospitals for high rehospitalization rates, and they penalize them for if someone gets a hospital-related infection while they're in the hospital. So if you go in for a broken leg and you come out with MRSA, there's a penalty that the hospital pays for the transmission of that infection. So that's supposed to encourage better care and better management of the environment in hospitals. What it really means, though, is that they turn us out even faster after surgeries, right? Because they want to get you out so you don't get an infection while you're in there. And the fact is that we heal better at home, we have less risk of infection in our own home. All these things are true, but sometimes it feels like you're being pushed out of the hospital maybe before you're emotionally ready to go, right? So it's a balancing act. We're trying.
Excuse me.
Yes.
I have another point is this. It's not means that you cannot stay in the hospital longer. One of the reasons hospitals don't like you to the patient stay longer. The reason is because the inpatient and outpatient, the financial the situation for the hospitals. Because according to the law, if the patient in the hospital and the payment for the hospital is very limited. So as I'm doing the radiation therapy, I can tell that very terrible situation. For example, like if the patient stay in the St. Joe Hospital, but hospital needed to let this patient to doing some kind of radiation treatment. But if you're doing the radiation treatment in the hospital, if everything included in all this bill, that means hospital don't get anything.
Mm-hmm.
Some hospital discharge this patient and send this patient as outpatient and treat it, after treated, then get a patient back to hospital.
Right.
So that just means that the anything has a loophole, and this loophole is if the smart people find out a way to manipulate, and then we are turning to a chess, and they play us as a chess.
Yeah.
That's a very sensitive, very sad situation.
Yes. We have this constant struggle in the history of Medicare and Medicaid, for example, between paying by the condition and you get as much care as you need, and the provider gets paid once, and then that didn't work, so then we started paying by the visit, and then people started taking advantage of pay by visit. The providers started taking advantage of pay by visit. So then we go back and forth all the time, like do you pay for a health event, or do you pay for the individual services received during the health event? And that struggle, there's someone always benefits more by one model or the other, but the only person who doesn't really get the benefit of whichever model we choose for reimbursement is the patient, right? Because we get kind of shuffled around, like you said, like pawns on a chessboard. So in 2008, I had a bilateral mastectomy and reconstruction, and I was hospitalized for a week. And at 5 days, my insurance company started saying, you really ought to go home. And I was begging them not to send me home because I couldn't lift anything or move my arms or even hoist myself up in the bed yet. And I'm like, you can't send me home like this, that's ridiculous. Like, I'll stay as long as I can make my insurance pay to stay. So those 2 extra days were like phenomenal advancements for me in terms of being able to take a shower and walk farther in the hallway. But if they had sent me home early, I don't know what my outcomes would have been compared to if they let me stay those 2 days. So as a patient, you sort of have to be your own best advocate, right? When the discharge planner comes in, they're going to try to get you out as soon as possible. And so you have to sort of advocate, well, how long can I actually stay? If I don't want to go home right now, like I still need to set up care with my kids at home, or I still need to hire an aide, or whatever it is, I still need a ramp put on my house, whatever it is, they can't just shove you out. You get to say, if you want to stay longer, is there room in my insurance for me to stay longer? Yes.
The longer the people stay in the hospital, the more infections they get.
Right, so that's the risk you're balancing against whether or not you're actually ready to go home.
You're
Well,
home
there's-
sicker than when you went in.
Right.
There's rehab too, right, as a.
Right, inpatient rehab is an option. So if you've had at least a 3-day hospital stay, then inpatient rehab is an option. Although many people don't want to go in inpatient rehab because they're afraid they're not going to come out, right? And then suddenly you're in a nursing home. So if you can arrange for appropriate care at home and access to outpatient rehab, then you at least might feel better because you're in your own home as opposed to in an institution.
We have a saying amongst my friends, if you want to get sick, go to a hospital.
If you want to get sleep deprived, go to a hospital because there's no sleeping happening in the hospital. None. Yes.
If you look at infections in hospitals over the last 10 years, what's happened? Is it going up, is it staying level, is it going down?
I do not know the answer to that question. I know they're trying to drive it down by incentivizing hospitals to do better infection management. And most hospitals now have an infectious disease expert whose job is really to try to limit the transmission of infections. So if you're in a hospital room visiting a friend, or if you're a patient in a hospital room, every staff that comes in there should be using hand sanitizer or washing their hands as they're walking in. It's like policy in most hospitals to try to limit the carry of other germs into the patient's room. And they should never touch a patient unless they've washed their hands or used hand sanitizer. Yes?
I think that the answer for that, infection in the hospital, I think it divided into 2 different categories. One category is, for example, like if I want to do my hip replacement in the hospital, and the hospital definitely has the data about how many patients doing this procedure and how many patients getting infected, and that must be reported to the
Right.
health department. So that number cannot be ignored. But another infection is, for example, is stay in the hospital, taking care of my care. The question is, I get infected because, for example, like sometimes the nurse didn't wash their hand, nurse didn't wear the mask, and infected to me, and I get more infected and more sick, and that kind of situation turn into like nobody know. Nobody know.
Well,
Because
right,
you are patient anyway, so I didn't touch you. I only give you the medicine, and you get infected for some other thing. Like you go into the society, everywhere you can be infected.
Right, but if you get that infection while you're in the hospital, it counts against them in terms of their reimbursement. It does. So, because it's a hospital-acquired infection. So it's not just whether or not the infection happens during the surgical procedure. It's like at any time during the hospital stay, if you end up getting an infection that you didn't have when you came in, and they can't prove that you had a dormant infection when you came in, then they're responsible for that infection, and that counts against them. So I think all that data is available somewhere. I just don't know what the numbers and the rates are. I know that one of the goals of the Affordable Care Act was to try to reduce that because of the spread of MRSA, right? Once you get MRSA, it's really hard to get rid of it. So we're trying to eliminate as many infections as possible so we don't have to treat with too many antibiotics, which can lead to then the antibiotic-resistant bacteria that's MRSA. Okay. Where was I on this slide?
You finished there?
Transitions, I think.
Transitions.
Yeah.
So then the next point I wanted to make is that when you look at the 3 different levels, system level, community level, family and individual level, you can see that there are risk factors at one level that can impact risk factors at another level. So I'm going to try to give you a couple examples, and I'll try to make it clear enough so it doesn't get confusing, because it can be confusing. So on the community level, for example, someone might struggle with chronic disease management. That's a community level factor. And they may struggle with chronic disease management because of inadequate community resources or poor care coordination, right, which are community level factors. These struggles with chronic disease management or episodes of acute illness can lead to hospitalization, which is an individual level risk factor, which is linked to all other kinds of individual level risk factors. That hospitalization can result in hospitalization-associated disability or anxiety or depression, which we have identified as system level factors. These in turn can lead to physical limitations and poor self-perceived health or negative impacts on emotional well-being or mental well-being, which again are individual level risk factors. So the triggers on the different levels interact with each other as well as with other triggers on that same level. This is why it can be really hard to tease out what happened to an older adult who, it looked very simple, like they had a fall, right? But the fall could have been the result of a multiple risk factor experience, and then leads to other risk factors that can lead to that spiral of decline. So it's really important to try to tease out, like, what level of risk are we talking about, and to identify them in categories is a way to try to help us structure our thinking around how to address those things and prevent those risk experiences. Does that make sense? So this spiral that I'm talking about, how many of you have seen someone, an older adult, go through that spiral? Right, and so were you able to identify like the specific moment when the spiral began? You were.
Sort of.
Sort of.
I mean, what, yeah.
It's usually pretty inwoven and like
Well,
interacted.
yeah.
I mean, like-
Right. So it might seem like one thing, but there could be like 3 or 4 other things that happened around the same time, and it's hard to sometimes figure out which happened first. So to try to figure out what those specific events are, and to try to anticipate them by planning for them, you might be able to eliminate some of the spiral, or at least delay the start of the spiral, or slow it down once it starts happening, right? But only if you can identify, and only if we have interventions that target the risk factors that people are at greatest risk for.
You gotta have a safety valve.
A safety valve?
Safety valve, your kids call you every day, your constant all day, checks on you, people down the street, something like that.
Yeah, we do that to my father-in-law whether he wants it or not, right? My dad hated it, the daily phone calls. How you doing today, Dad? Well, what do you think I am, an invalid? Well, yeah, you actually are housebound, so how are you doing today? But it's a struggle. Like you want people to know what's happening, but you don't want people monitoring you every day like you're incompetent, right? So there's got to be some balance in between. It's just hard to strike that balance. Adult children's anxiety about what could happen to you could impose on you limitations that lead to risk factors that could cause that thing to happen to you.
And it impacts them, Maria.
And yes, it impacts them.
That's right.
They're worrying about you, and the time that they spend devoted to that worrying impacts everybody.
Well, if something happens to you, if something happens to you and they live out of town, that means they gotta step back and forth keeping an eye on you. Or they gotta find somebody, they're gonna incur an expense. It doesn't end.
No. So this is the thing about our society, right? Living as long as we live now is a relatively new phenomenon, and families when families all stayed in the same town and all lived like in the same area next to each other, it would have been a lot easier to manage the aging of a parent, except back then people died a lot sooner, right? And then once we started spreading across the country and our kids moved to all ends of the country, now we're living like an extra 30 years, and they're not localized anymore because our society has become a different kind of mobile society. So it is a constant balancing act if you have kids out of town, or if you have like one kid in town and 5 kids out of town. That one kid in town ends up being the epicenter of all the caregiving and all the worrying, and then that can cause problems between the siblings, right? If they're not all sharing in the...
Well, some of us in this room may share my experience that my eldest child is an older adult.
Right.
And
Right.
the other 2 are fast becoming older adults.
Right,
So
right.
they're older adults and I'm an older adult. So there's this mutuality. I worry about them
Right.
and they worry about me. We don't often speak of it, but it's there.
It's there, exactly.
You know, and worrying about, are they gonna get sick and need care for me who's older than they are?
Right. In social sciences, we refer to that as the intergenerational transfer of care, right?
Yeah.
You care for them, they care for you.
Yeah.
When they're little, there's also an intergenerational transfer of care, mostly down to them. And then
Yeah, right.
when most of us are middle-aged, the intergenerational transfer of care is up to our parents. But with people living longer and longer, there's this
children
loop
are-
developing, even if I remember being in a diner in the Adirondacks a couple of years ago, and there was this family of 3 women, mother, daughter, granddaughter, I guess. And the granddaughter was like in her 40s, like me. And her mother was like in her 60s or 70s, I think, and was on oxygen for COPD. And her mother was like 95. And when they got up to leave, the grandmother and the daughter were kind of holding the mother up as they walked out the door. And I thought, well, there's an intergenerational caregiving family right there, right? They're all worrying about each other in some way or form. And that's more common the longer that we live. Yeah. Okay. So then the next challenge is, once we've identified what these risks are, how do we find people who are actually facing these risks, right? Like, how do we identify them? So there are a variety of ways. And some of the research points to using the Sherburne postal questionnaire, which allows you to mail the questionnaire to someone at home. They fill it out themselves, and they assess their own level of risk, and then they send it back into their doctor. And the doctor decides, based on that risk assessment that they did at home, whether or not that person might benefit from a more comprehensive risk analysis, right? So that you may see from the questionnaire that they're fine, they've thought of everything, they're fine, or they're in good health and they're fine. Or you might see risks that they didn't really know they had until they started filling out the form, and you didn't know they had because you only have 15 minutes with them in the doctor's office, and how much can you cover in 15 minutes, right? So once you've identified that they are at some risk of frailty, then you can use either the Comprehensive Frailty Assessment Index, which is an in-home assessment. So you can send your social worker or your care manager out to their home, and they assess psychological, physical, social, and environmental domains for risk. Like, are there a lot of loose area rugs that they could trip over, right? Is there a lot of boxes piling up? My father had boxes upon boxes, like, lining his hallways, and I'm like, Dad, I don't know why you keep stubbing your toes. Right? So these are things that you kind of get used to in your own home environment. When a fresh set of eyes walks in, they can see the risks are like neon green to them, whereas for you, they're just a thing you're avoiding every morning when you get out of bed, right? So that's a comprehensive in-home risk assessment. The other risk assessment you can do can be done in primary care. So that's called the PRISMA 7, and it may also be useful in emergency room visits as well. But we don't systematically do these assessments. So if you go into an emergency room visit or a doctor's visit, they address the presenting issue. And there's really not enough time or reimbursement for time to do a full assessment of all the possible issues around that presenting issue that may not be visible in that 15, 20-minute interaction. So those are ways to identify them. And the other way to identify at-risk populations is to look at population-level data. So look at things like how many people in an area are 85 or older, because that's a group that's at risk of frailty. Or how many people are disabled and living in poverty, or how many people report very high numbers of days of activity limitation within a month. So those are ways. So there's some data sources. This is census data. And the thing I wanted to point out here is that this is Onondaga County. So we have a fairly high concentration of people age 85 or older. But the thing with census data is that that range in that dark purple is from 2.5% to 13%. So there's no way to know from census data really how many people in each of these census tracts are 85 or older, what percentage of them are. And the other thing to bear in mind when you're looking at data like this is that the census data often includes people living at home and people living in institutions. So there may be an overrepresentation of community-based risk because a lot of those people might be living in assisted living or in nursing homes. So this is one of the challenges, and one of the things that we propose in the policy brief is that we need to do a better job of data collection about these risk factors. Because right now it's very hard to find adequate data to tell us where these people are that are at risk.
Sorry, it's hard for me to read it, and I don't know if it's hard for people in the back. The darker colors are the higher numbers?
Yes, darker colors are higher numbers.
How do those people exist up there?
I was going to say, where
I
is
mean, where do they
that?
get their care?
This is a percentage of the population. So it could be a very rural area, and the population might be relatively low, but a lot of these folks, you're talking about these folks?
Yeah.
Yeah, so a lot of those folks are, maybe they were farmers, and their kids grew up and moved away, and they stayed because that's where they had their investment in the land, right? And so you get to a point where you're in advanced elder years and you don't want to give up your home, and then there you are. Now, some of these things, like there's a census tract over here. I want to say it's this one. There's a prison in there.
Yeah.
And so it's like 100% people over the age of 65 with disabilities, I think. But the only thing in there is a prison.
Oh, wow.
So that's the other thing, is the aging of prisoners and the inappropriate
That's another
management of aging in
crazy
prisons.
subject.
Yeah.
If you, and does anyone here watch Orange is the New Black?
Yeah.
I'm not the only one. They have an episode in season 3 where this elderly woman is like really like demented, right? She's got no memory, she's looking for a husband, she wanders off the camp into the town, and their answer, because they don't know what to do with her, is compassionate release. And they drive her to the bus station, they leave her there. This happens to older prisoners. There are very few prisons in this country that have dementia wards. There's one in New Jersey, I think, that opened their dementia ward in like 2004, and it was like earth-shattering. Earth-shattering idea that you have so many people with dementia that need a ward, but every hospital, you've got lifers, you have people developing dementia.
Sure.
Right? And these populations are already higher risk for health problems because of the lifestyle they led before they got in, or the poverty they experienced in childhood, or whatever it was. So they're at higher risk anyway for dementia.
I think the state would want to bail.
Bail how? Compassionate release.
Yeah.
Okay, compassion.
Leave
Find
them
some
in
way to not keep them in prison, but keep them,
Right, but
Well, where?
the model of compassionate release that they often use abandons you to the community that has no resources for you either. Right? If you've been in prison all your life, what's the chances that you're getting Medicare? Did you contribute to Medicare? No, you did not. Did you contribute to Social Security? No, you did not. So you get out of prison and you're like 80 and you don't have any Medicare, you don't have any Social Security.
And you don't qualify because you don't live in that area.
Right.
So if you're released on the western New York, but you're released to Syracuse, you have no.
don't go to prison.
Well, that's a good thing.
Believe me, some of these
I'm
folks
not
didn't.
planning on it.
Some of the folks who end up in prison their whole lives never intended to be there. I mean, we could talk a whole nother conversation on false convictions, but I won't go there. That's a very popular podcast topic now, false convictions. Okay, so what else can I say? Oh, so this is like a snapshot of age and disability and poverty in some of the counties in western and central New York. So the 3 counties at the top, Allegheny, Cattaraugus, and Niagara, are in western New York. Niagara is where you think it is. It's the upper half of Buffalo, but in the Niagara Falls, Buffalo area. Allegheny and Cattaraugus are down on like the southern edge of the state, very rural. And these 3 counties have fairly high concentrations of people aged 65 and older. At least 15% of the population of those counties is 65 or older. And then of the people who are 65, 37, 38, and 33% of them are disabled, in addition to being older. And then of those with disability who are 65 and older, like about 5% are also living in poverty. So these are pretty high rates compared to the other counties in that region. That's why I highlighted it in the table. And you see similar numbers for Cortland, Herkimer, and Oneida counties, which are all basically rural, although they have some pockets of urban areas in those counties.
How do you define disability?
Disability is like any impairment that limits your ability to do activities of daily living. So if you can't walk without assistance, you'd be in the disability category. If you couldn't feed yourself or toilet yourself, you'd be pretty severely disabled. What was your question?
I have a question. Why isn't Oswego County over there that borders Onondaga?
Because Oswego County isn't as bad off as those 3 counties that I included on the table. So I had to cut off somewhere so we wouldn't be overwhelmed by the number of counties. And Oswego County actually doesn't do as poorly as some of the other counties in terms of risk factors for
Well,
older
I have a
adults.
sister-in-law that lives over there on the other side of Oneida Lake, and they do not have any of the services that we have over
They
there.
don't. We're a very service-rich county. But the data doesn't reflect the services they get as much as the level of need that they have. And remember, whenever we talk about data or statistics on a population level, those statistics may not represent an individual's personal experience, right? So the picture of the overall population might be less dire, but that doesn't mean that one individual isn't at great risk. They're just lost in the data, and we don't have a good way of identifying them through the data, which is one of the challenges that we're talking about in the policy brief. They are rendered invisible by insufficient attention being paid to them. And how do we get through that? But I agree, I mean, we have a lot of really great resources that the rural counties around us do not have. And some of those resources reach, though. Like, we have the Center for Excellence for Alzheimer's Disease at Upstate Hospital, Dr. Sharon Brangman. I don't know if any of you have ever heard of Dr. Brangman.
Yes.
She does phenomenal work there. She actually covers an 11-county area, which would include Oswego County. But how do you get to her if you live out in the rural areas, right? So she's been working with rural medicine program at Upstate to try to get more appropriate education out to rural doctors so they can identify people in need out there. And similarly, the Alzheimer's Association covers a 14-county area. But again, they have to go out into those counties, and they're working, part of the state program that the governor's funding for dementia caregiving is getting them out there and working with other organizations in those rural counties to deliver their resources in that way. So we're trying to reach out into the other counties in some of those capacities. But you're right, they're very isolated in some cases, and they don't have the resources that we have. They might have an office for aging, but their office for aging, maybe they do Meals on Wheels. You know? And they got cuts to their budget, I know, a couple of years ago for nutrition even, because the numbers of older adults were shrinking. And that's the problem with a lot of aging network resources are based on the head count of how many older adults live in your county. And so if you don't have enough to sustain like congregate meals, then you don't provide them anymore. There are some people that are still there though that need those meals, and they're getting kind of lost.
So actually, your individual trigger, all this category can be summarized as one summary. This means poor and rich. That means that if the poor patient or poor elder, every item you will get in the limit. If you are rich, I tell you, if I rich, I don't have the malnutrition part, nothing. So that means discovered, recently published a paper by Linda Massa. I think that she statistically said the poor and the rich people, the age life, the average life is about the 12.2 year difference.
Right.
That means the rich people live longer than poor.
Right.
So,
And
12
that
years
gap
difference.
is greater.
12 years average difference.
12.2
Yeah.
year difference.
And that gap is greater in the US than in many other developed countries because of the resources that are provided to the poor in those other countries that are not provided to the poor here. The other population to think about is there's the people who are poor by federal poverty level standards. Then there's people who live within 200% of that level of poverty. So they're not so poor that they qualify for government programming, but they don't really have any money to spare, right? Because the federal poverty level itself is a pretty stingy number. And like the way it's defined, it doesn't really make any sense in our modern society. It's based on this old equation from like the 1960s. So people, they're using their money in different ways. Housing costs are much higher now, say, than they were when the formula was established. And medication costs are way higher than they were in the 60s, right? The longer you live, the more medications you're on, and then your income is split between all of these factors, and even 200% above the poverty level doesn't cover all your costs. So how are you going to come up with money to pay someone to come in and clean for you if you can no longer push a vacuum? Or to come in and help with your meals if you're having trouble managing the utensils on the stove, if you are barely making enough money. So even the working poor, people who are working poor but not living on welfare their whole lives, are still very vulnerable. And people who are even middle class don't qualify for some programs and could exhaust all their resources in very short time. If we live 30 years past retirement, You know, you gotta have that money saved. If you were like a middle working class person your whole life, do you have that money saved? Will Social Security cover it? These are all questions people need to think about. I used to teach a class on aging policy, and I used to tell my graduate students, you really all should get a Prozac prescription before we start. Because it can be depressing. So one of the ways I try to counteract that depression myself is to work on projects like this that promote the idea of doing a better job at collecting data about these folks, better job at looking at evidence-based practice that can benefit people who are at risk. You know, like that's the way to get around that depressive feeling. So when I searched for the evidence base to find out what was out there in terms of programs addressing triggers, I found programs for the list of individual triggers you see on the screen, which is just a very small set of those triggers. Yes?
It seems to me though that when there's a problem developing within the family, that it's very difficult to determine where you should go. How do I get help? Where do I go to get help? Is there a directory of that? Even when, say, in a family you have a mental illness issue developing in the family, it's very difficult to determine who do I go to? How can I get help? Where do I go?
That's a great question. And the answer is for Onondaga County, which is a very resource-rich county, I'm not online.
Look at you.
There you go. Does anyone know the password?
Manlius Library.
Is there any capitalization or?
I think it's all lowercase.
No, capital M, I believe.
Oh.
Maybe there is no
You'll
case
find out
sensitive.
soon.
If I could type, that would help, wouldn't it?
You can see the keyboard.
Well, yeah.
Well, this is.
Okay, so Manlius Library, capital M, capital L, people.
Is that what it is?
Okay, so ongov.net
There you go.
is the website for all things Onondaga County. If you go to the departments link up at the top and look at the different departments and agencies, you will see aging services. And under aging services, you will see aging services again. And inside that category, well, first of all, a list of all the services provided by the Office for Aging. If you're not familiar with this list, take a look. You or someone you know might benefit from it. But also in that list is this resource guide. This was recently updated, so it's actually pretty current. And this resource guide will tell you what services are available for whatever problem that you have. So
Most
there's
people don't know that though.
No, it's true.
Can I just add something?
Yes.
We probably get, on average, I would say 10 calls a week for people looking for services. We do make referrals because we have relationships with people in the community. That some organizations, I'm not sure the government is able to do that as freely as we are. We have an outreach worker here who will come and sit with you and help you, and that is a government person.
Right.
But, so we have lots of relationships at the senior center that, you know, we can help a little bit. And that would be one of the things we would suggest
Right.
too, is the office of.
Does everybody
the senior
understand
center.
that this informed setup started with the senior center? And everybody here should have some connectivity to the senior center, preferably a membership. Did I say the right thing?
Yeah, that's fine. We'll let Marie.
Okay.
I just want.
So,
See if we also have.
I just want to say, I'll tell you that I've been to senior centers, this senior center and senior centers at different locations in the city, and predominantly, the people who come to senior centers are white, heterosexual older adults.
Right.
So that's two populations are already invisible in most senior centers, which are people of color and people who are sexual and gender minorities. So that means that those folks, they don't come or they're not, well, you can't be invisible if you're a person of color, but LGBT older adults can be invisible. They can show up and just pretend they're not gay or trans and hide in plain sight to have access to services. But most of them won't even do that because they're used to being open and then they have to go back in the closet. So senior centers are great if you feel comfortable going to them and accessing the resources, but not all older adults do. So not everyone who needs help knows to come to a senior center to begin with. And then if they're not connected with the aging network in some way, like through a senior center, may not be aware that we even have an office for aging, or even that all of these services are available in our county. So the Office for Aging doesn't provide all of these services, but they subcontract to agencies that do, or they list providers of services that they don't themselves provide. So there's a whole section on food and nutrition, housing, guides to senior housing, like what's an ombudsman, what are your rights if you live in senior housing, transportation resources. Look at the category on caregiver and home care assistance.
Is this list available in print?
Well, now you want everything. The Office for Aging may be able to provide print copies, but one of the things about this list is that it's constantly changing. So you could have a paper copy from like 2010 or 2012 or even 2016. A couple years from now, some of these agencies might not be on there. There might be new things that aren't on the written list. But you could call the Office for Aging and see if there's a print copy.
But they'll send you a print of a section too.
Right,
So if
based
you
on the
want
problem
housing-
you identify it. Because the whole thing is pretty long.
You can see how many pages.
Yeah, it's like a few hundred-page document. So, but if you're interested in things like end-of-life issues, they can send you just those pages that address end-of-life, advanced care planning, and all that stuff. Healthcare, health benefits, financial issues, legal services, services for veterans. If you're a grandparent raising grandkids, there's a section for you. See how small the section is for LGBT resources? So sad. And then they get into the details of what the program is and how you reach out to them and what their mission is and stuff like that. So that's why it's like 300 pages, because then there's this whole list of the offices across the county, across the state in every county. So it is a pretty big document. And 2016 is pretty impressive, since the 2005 list was up there until like 2015.
Yeah.
Yes.
As a licensed social worker of 40 years or more, I need to tell this audience, if they don't already know, that mental health services for the elderly, very, very difficult. If I wanted to be reimbursed by Medicare, I'd have to go through a big procedure, and then they decide how much they're gonna give me, which is only a fraction of what I would charge, and that's true for psychiatrists as well as psychologists.
And
So it's a real, real problem. There are not mental health providers for the elderly in this community
Right.
or any other.
Reimbursement is poor, and also there aren't that many people choosing that as a specialty.
Right.
Geropsychiatry or geropsychology, very few people who actually practice or are well versed in the issues that actually address older adults.
Yeah, so, you know, this is generally a big problem when we talk about when there's an act of violence on a young person and who is diagnosed as mentally ill, and immediately people say, well, why don't they get therapy? Well, this is a problem.
Right.
There aren't the therapists.
And we've known for a long time that there's a problem of parity between what's covered for physical health and what's covered for mental health. I mean, how many of us have heard stories about families whose kids are in rehab and the insurance runs out and they gotta take the kid out of rehab before they're really ready, and then they end up relapsing in drug abuse or whatever, or people who have anorexia and they die of it because they run out of insurance money to cover hospitalization.
So that's another instance where if you're rich or the family is rich,
You have
they
resources
can
other people
afford
don't.
to pay out of pocket for
Right.
their relatives to
If
get
they're
some
willing to
help.
do that.
If they're willing to do that.
If they're willing.
So this is what we hear all the time about how high taxes are in this country, but actually there are other countries that have much higher tax rates, but way better services to protect their citizenry too. So it's a trade-off. I always try to explain to my libertarian brothers, and they just don't get it because they're middle-class guys who have money and insurance and they feel pretty safe. Yes?
What are the three largest contributors to decline in health?
The three largest contributors?
Age.
Well,
Number one.
You know, as we age, what are the things, three major things we should be looking at?
physical health and mobility would be very important. So taking medications as prescribed, every once in a while having someone check to make sure that all your medications are working in concert to make you healthier rather than less healthy. So oftentimes Dr. Brangman might have people show up at her dementia clinic and the family thinks, oh, they have dementia, but really they have a medication that's causing the symptoms of dementia. So you want to hold your doctors accountable. Like every time they put you on a new medication, have that conversation. What are the chances that this is going to interact with other medications? Once you're taking more than 6 prescription medications, your risk of medications interactions leading to death is elevated. So you need to, this is not to say that you should just refuse to take medication, but you need to do some very practical medication management conversations with your doctor about what you're taking and why you're taking them. And you still need to be on the medication I was put on in the hospital 3 years ago. Or was that, sometimes that happens. Like you get on a medication for a health crisis and everyone just assumes you're on it. Whether you need it or they don't know if you need it, they just leave you on it. So every once in a while you have to kind of review those. So when they say bring your medication list or your medication bottles, hold them accountable. Say, I brought all my pill bottles, now talk to me about those. Right? Don't just tell me to bring them and then say, are you still taking XYZ and then that's it. Like talk to me about how many medications I'm on. So I would say medication management is like a very big risk factor.
Lack of social network.
Social isolation is a big risk factor. And I would say that leads to other risk factors like depression related to losses that you experience in later life. And I would say falling is a pretty big risk factor. So I don't know if you're aware, but a lot of people fall not because they have bad balance, but because their ankles are weak, right? So you want to try to do exercises that strengthen your lower legs and your ankles as well as maintain your balance. Tai Chi is really great for balance, but you need to do other exercises to keep your muscles strong around your feet and your lower legs, because that also helps prevent falls.
Do you have a sense at all of, you know, in the medical community, doctors themselves being very unhappy with the system? Seems to me there's a lot of coming and going amongst doctors right now. Certainly doctors that I've gone to, people that are leaving practices, they're joining other practices, they're retiring early, because they're not really happy with the way things are going.
My oncologist, his name was Dr. Joe Navone. He was at HEMONC, and he retired and moved to Montana after he had cancer himself. And one of his reasons he gave me was it's very stressful trying to keep up with the pace they require of you in a medical setting. And so he went to practice in Montana where he would have a very small patient base and he could spend the hour, hour and a half that he liked to spend with his cancer patients that he couldn't spend at the practice because it cost the practice money, right? So, and that's why gerontologists don't make any money, geriatricians, they don't make any money because reimbursement for Medicare is like 15 minutes. And a geriatrician might spend half an hour to 45 minutes with you to try to get a comprehensive picture of everything that's going on in your life, and they just don't get reimbursed for that extra time. So I think there is a level of dissatisfaction among certain practices, certain professions of healthcare, right? But certain cardiologists, they have a whole infrastructure in place. They just come in and do the hard thing, and the system worries about the rest of you. I mean, it's very different for those kinds of specialists. But for some, like internists, probably very difficult for them right now in terms of lack of reimbursement and the fact that most of their patients are aging. I mean, we've been saying for years that in 2030, like there's going to be 20% of the population 65 and older because of the aging of the baby boomers. Well, 2030 is only 14 years away. We're in the middle right now of that push through the system of that generation, and there's not enough people practicing medicine that are familiar enough with the aging body to really do good practice, right?
Give a little plug for
Yeah, sure.
Dr. Brandon's office.
Yeah, sure.
I'm a social worker at University of Nutrition, and we spend with new patients, we allow an hour and a half to 2 hours to assess cognitive, physical, social factors that are impacting people. We also have the social workers so we can try and connect people with services that they need to live better lives. We don't do primary care. We work with your primary care physician to help you get that. But one of the biggest places that we refer to is the County Office of Aging to help you get the supports there and figure out how you can get people to help you. And it is a fact of life that, you know, if you have the financial means, you're much more likely to be able to afford the care that you need in your home. But there are services out there and connections that you can get that can help you come in and help.
Do you need a referral?
You do not need a referral. You can, we do not actually take referrals directly from the primary care. We prefer to talk to the patients or their families themselves so that we can get an appointment that would work well with them, for them in their schedules, instead of just saying, okay, come in at Thursday at 10, if you can't, you know, that might not work with your schedule. So
We couldn't hear back here, where are you talking about?
I'm talking about, I'm sorry, University Geriatricians, where Dr. Maria.
Right, the Center for Excellence on Alzheimer's Disease, which is run out of upstate. It's at 550 Harrison Street. And one of the reasons why, my understanding, I did my social work internship there years ago, but one of my understandings at the time was the reason why they don't require referrals is because some primary care doctors might be offended by the idea that you want to go and see a geriatrician. So then they bypass that, and back then, oftentimes the doctors that were most offended were as old as the patients who were looking for the referral, and so they just don't want to feel like you think they're not taking care of you the way they should be taking care of you. But the fact is that sometimes you need a second opinion. Things are changing in your life and in your mind and in your perception, and you want someone to help you with that, and your doctor may not be trained enough to do more than a very minimalist examination of your mental status that may or may not identify the real cause of the problem.
Right.
Sometimes people think that they're starting to get dementia, but they're really depressed, or they have medication interactions that are causing the symptoms, and Dr. Brengman can tease that out for you in that time that they spend. Yes?
I was trying to be proactive and switch to a geriatric doctor. As getting older, they would have more insight about medications, different things. And when I called and I gave them a list of names that I had researched, I was told and asked, do I have dementia? And I said no. They said, we only take people with dementia.
That's not true. That,
You know, because I tried to
anybody
get into
over the age of
Bragman,
65.
and there was a few people I knew from my past profession that I was trying to get in, and that's what I was told.
Well, if you're trying to get in for primary care, then Dr. Brengman doesn't do primary care.
Right, but any of them would not take.
Nobody offers primary care services in our office. We
Right.
work with your primary care physician.
Right, that's what I found out.
And the
yeah.
requirement is you need to be over 65. And,
Right.
and we also have wonderful nurse practitioners, and we have fellows who come through, so we're training them. They're already physicians, but we're giving that geriatric piece so that we can hopefully train more people to be able to do this kind of
So
work.
does a person need a primary care doctor as
Yes.
well?
Yeah.
Because you
That's
work
good to know.
with them.
I know someone that just made an appointment there, thinking that was gonna be her primary.
Well, they might refer her to a good primary care doctor, but they won't be able to provide primary care. There's just too many people who need dementia services to also provide primary care.
And what if you decide that maybe you are coming down with dementia? Wouldn't they take you to?
Then they would
that?
certainly, they would meet with you and do the assessment. Yep,
Yes.
they would definitely do that.
That's what we do.
They would meet with you and do the assessment.
I didn't mean to.
It's okay, Karen, it's all right. It's all right. So Karen's got a card, a business card. I have business cards.
Calling cards.
Calling cards, whatever you want to call them. And oftentimes, if you find yourself with questions about getting proper care, health care as an older adult, you can call, I'm going to say this whether you like it or not, you can call university geriatricians and ask them, and they can make referrals for you over the phone. Like if you say, oh, I have these symptoms, they can say, you should see a geriatrician at this practice, they'd be good with that. Or if you want someone to come in and clean your house, if you don't want to call the office for aging, you want to call a doctor's office instead, they can make referrals for stuff like that.
To the office of aging.
Right. Well, Nancy Calhoun used to be the social worker there, and she had like a whole cadre of private providers, like LPNs, that would help you with medication management at home that you didn't have to go through a doctor's office or a county to get. So there are some people out there providing that kind of private services, but either the Office for Aging or a university geriatrician might be able to point in the direction of those folks. So, any other questions?
So I have a question. You're doing this research, and then will you present it to
You have to be a
people
little
from the-
louder.
I'm asking about if you are doing this research and you get these results, then will the Affordable Care Act be impacted by it? Will they learn to take what you found out and improve the services that we get?
Well, the Affordable Care Act funds an institute called the Patient-Centered Outcomes Research Institute, or PCORI. You've heard of that. And so PCORI provides funding to do what they call comparative effectiveness research between one evidence-based practice and another. And then you prove to them which evidence-based practice was most effective in addressing the problem you're targeting. So in our case, it's going to be chronic disease management. So which program is more effective at targeting chronic disease management issues for older adults in minority populations, A or B? And that information goes back to them, and they add that to the evidence base, that this intervention works better with, lower income minority adults in the upstate New York area, so it adds to the evidence base that way.
Okay, and then it will hopefully change policy or practice.
Right, hopefully it will influence the services being offered, right? So the County Office for Aging used to offer chronic disease management.
They do.
And they offer it through Oasis, which is a program at Upstate Hospital. But it's mostly being delivered in white, rural, and suburban settings. And so the challenge that we're looking at in our grant proposal is how to bring that into minority communities or find another invention that works better with minority communities who have more limited resources and time than required for that program. So, yeah, so people are working on trying to beef up the evidence base.
Next week, we continue with the Aging Studies Institute presentation. The speaker will be Paul Gold, and he will speak on food for thought, chemicals that change the mind. Think about what you eat and how it possibly changes your mind. Thank you for coming. Spread the word.
Thank you.